Thank you, Rohan. Thank you, Pooja, and the entire IRSI team for putting this program together and having me here. You see two people here, doing a handshake. So I just want to, before I begin, I just want to say I have been given a topic of gizmo attack, the future of dry eye diagnostics. But I would say there is no debate in this because as we have discussed, my previous speakers have discussed about the subspecialty clinic, the treatment and everything. I think by now we have started getting an idea that it is a clinical parameters, your clinical examination and gizmo diagnostics, which is the imaging diagnostics, have to go hand in hand. And there is nothing like a separate thing. And I have no financial interest in what I'm going to speak. So I would just like to start with this quote that, in our medical practice or in our life, we've learned this, that the only thing constant in life is change. And we have been seeing this. For example, when we do our microorganism analysis for our infections or anything, when we started, it started we just had our staining techniques or a microscope to see what we are dealing with, what kind of microorganism we are dealing with. Then come the culture sensitivity. And now we are in the era that, everything has started becoming a microgenomic analysis, including our pandemic, the COVID-19. It's all about a microgenomic analysis because the culture and sensitivity is not going to give you the answer. Same thing is with dry diagnostics. The evaluation, initially we started with just the retail history. Based on your history, you were treating the patients. Then came your Schirmer's test and staining techniques, and you used to treat your patients. But I feel that no, as everything is evolving, the world is changing, and the change is necessary. Imaging diagnostics also play a very important role in our dry eye practice. So these are just a plethora of diagnostics of what all we can have in clinic to diagnose our dry eye practice. And I will just show in next few cases about why each of it might be important. Not probably at this point of time, but yes, it is the way to your future. And it's not just about diagnostics. I would say that advanced therapeutics are equally important, because my previous speakers did highlight the role of some said about the vector pulsation therapy, some spoke about the IPL therapy. So we are in an era of customization where only the clinical history might not play a role. So let's see a few case scenarios. These are two patients who wanted to get a cataract surgery done, multifocal. I'm just going to run through this case because Dr. Kumar has made my life, my talk, very simple. He underwent a multifocal eye surgery day one. In fact, on his follow-ups, he had a well-centered multifocal IOL. But the patient one had 6/6 vision, no complaints. But the patient two had 6/6 N6 vision with a lot of complaints of persistent glare post-operatively. So what happened here? We went back and we had done a test on the ocular quality system analyzer just to see how the tear film quality is. As I said, preoperatively, Schirmer's staining and everything was normal, but still the second patient had persistent glare complaints. Retrospectively, we went back and checked the tear film. The ocular scatter index in the second patient was extremely abnormal. It was like, you can see this, and it is it is visible that it was extremely abnormal compared to the first patient. And this is the V-bud. The first patient had a very stable vision, but the second patient had abnormal V-bud, which is vision breakup time is nothing but like your T-bud, but it gives a little more advanced thing of what is happening to your quality of vision with time. So this just explained us that we had, even though our dry diagnostics was normal, but we had missed something on the tear film quality, which is probably making the patient unhappy. And we did a vector pulsation therapy for this patient. This is how the pre-op looked like, and this is how the post-op looked like. And the patient is extremely happy now without removing. We were planning to remove the multifocal IOL, but we did not remove. We just treated him with vector pulsation therapy, which improved the tear film quality, and it made him happy. The second scenario is there's two patients again. T-buds were normal, a mild MGD, but they had a lot of inflammation complaint. They had a lot of discomfort complaint in their eyes. So we did give them a dry eye therapy, but after 3 months, the first patient did not improve, and the second patient in fact, she worsened on her discomfort scale, and the second patient had a good improvement. The inflammation, the discomfort reduced by half. So we rewind, let's go rewind. Just for our research interest, we had done a confocal microscopy for this patient. If you see, the first patient has a microneuroma here. The nerves are healthy and there are no dendritic cells. Whereas the second patient has a lot of dendritic cells. Dendritic cells are nothing but the inflammatory cells. And the microneuroma are nothing but an abnormal nerve ending. So we came to know that, yes, we did treat the patients for considering that it was discomfort, we gave treatment for anti-inflammatory agents and lubricating drops and a dry eye therapy. but we missed out on the point that the patient had the neuropathic pain was due to a central pathology. It was because of microneuroma, not inflammation. And the second patient had pain without stain, which was inflammatory in nature, which was a local pathology. And that's why the patient improved with the treatment. Now, this is my third scenario, and which is the most important thing which we are dealing with. We are not only dealing with a COVID-19 pandemic, but we are dealing with a lot of other issues, like, for example, a mask. Like, I'll just stick on mask part. A mask on ocular surface and how it impacts the treatment outcome. We know that mask leads to dry eye. But is this dry eye similar to what you see in your normal dry eye clinic? The answer is, I'll give you the answer. What we did was we had samples of normal subjects, not any dry eye or anything before COVID. Luckily, we had those samples because of a study we were doing, and this was stored in our biorepository. But when the mask-associated dry eye came in, what we thought was, let's go back, take out the samples of the patients who have without any dry eye we had stored before COVID, without any mask use. These were all healthy, normal subjects, and we call the same patients, and we collected the tears and washed again to understand what was happening post-COVID, who are wearing different types of masks, and the mask hours of more than 8 hours. What we found was, which was very interesting. Of course, we did the normal clinical examination. The normal clinical examination showed the Schirmer's value was significantly higher post-mask wear. And the T-buds also increased post-mask wear. Along with, of course, discomfort is increasing. Why is this? If the patient has dry eye, the T-bud and Schirmer's should not increase, right? Also, on just to brief this, on tear fluid analysis, we found that the markers, yes, they were deranged, but the markers were the deranged were not the same as they are deranged in dry eye. We were seeing that there was a lot of markers which were present were higher due to higher mucin layers, okay, like higher mucin content in the tear film. Now let's understand. Anaga ma'am showed this chart again, made my job, my job simple. A normal dry eye, you deal with a tear hyperosmolarity dry eye, okay? That's a tear hyperosmolarity which leads to your dry eye. Here, because of your mask, it leads to enhanced evaporation of tear film, but here you're dealing with hypercapnia. There is increased exhaled hair, which is 90 times higher, which has a lot of hypercapnia producing on your surface, okay? Next, these are just the cells. First is what you see is the normal cells, how healthy your ocular cells are on the surface. And these are just after inducing hypercapnia. These are how dead your cells look like without any life in them. Like, you can hardly make out this thing. It is just because we have induced hypercapnia. And what we concluded from all these three things, I'll be just quick, is because I want to come to the point, is based on the Schirmer's T-bud, based on the tear film analysis, and based on our cell analysis, the HC cell analysis, what we found was that we were not dealing with hyperosmolar dry eye. We were dealing with a hypoosmolar dry eye. Yes, there is a mask-associated dry eye, but it is not hyper, it is hypo. Now, how does it impact my clinical practice? Again, you are dealing with a hyperosmolar dry eye. There is an increased mucin layer because of the hypercapnia, and that has an impact on your treatment. It will have a clinical impact. You need to have a different treatment approach, like judicious use of lubricating eye drops, but it has to be a customized eye drop. You cannot use you cannot use an osmoprotectant eye drop, because osmoprotectant eye drops controls the osmolarity of your tear film, or it reduces the hyperosmolarity. Here you need to increase the osmolarity. So probably Varun made my job simple. I just took a screenshot while he was giving his talk. We need treatment like alcohol-based lubricating drops like Cystine Ultra, no financial interest here, or a tree halos. Tree halos also works wonder in your hypoosmolar surface. So I'm just trying to point out here is we couldn't have found out this thing if we didn't have the tear diagnosis available with us. Yes, I'm talking about the future, but the future is about a tear diagnostic kit. When a patient walks in your clinic, you do a tear test, and within half an hour, you have your analysis of what type of a dry eye you're dealing with, whether it's inflammatory, non-inflammatory, whether it's hyperosmolar type of dry eye or hypoosmolar dry eye. So just to conclude, yes, ma'am, history and clinical examination are absolutely normal, but to make your practice stronger, and which all of us will agree, and I'm sure none of the speakers will disagree, we do need imaging modalities. As per the practice we have, will need a diagnostic kit like your glucometer kits or your pregnancy kit in your future. And yes, you will need advanced therapeutics to treat your patients. Maybe not now, but yes, it's like taking your baby steps into the future. Thank you.